Good evening and welcome to tonight's webinar. My name is Russell Burgum. I am an interventional orthobiologics physician with Regenexx in Des Moines, Iowa. And tonight we're going to talk about how to avoid elective orthopedic surgery and how to reduce pain with non-surgical treatments for orthopedic conditions using Regenexx techniques and procedures. Now, many people who will ask me, they'll say, Dr. Burgum, I know you're an expert in taking care of knees, but do you treat fingers or wrists or what about my big toe problem? Do you treat that? And I've been doing interventional, non-surgical, high-resolution image-guided procedures for 16 or 17 years. And at Regenexx Des Moines, we treat patients from head to toe. One area I do not do interventional injections in the spine, but for many years, I have been doing spine evaluations. In the past, when I worked in orthopedic clinics, I would assess patients to see who is a candidate and who is not a candidate for spinal surgery. And we are currently in the process of working on bringing on a physician to do spine injections in our clinic in Des Moines. But otherwise, shoulders, hips, knees, ankles, fingers, wrists, elbows, carpal tunnel syndrome. We can take care of all that in Des Moines. So Regenexx is a network of clinics throughout the country. Actually, there's Regenexx clinics opening up. We have them in Mexico. They're opening up overseas. Regenexx is a network of clinics that all use proprietary techniques and proprietary lab processing techniques to deliver the highest quality regenerative type treatments using the patient's own blood and the patient's own bone marrow or adipose tissue to deliver high concentrated platelets or mesenchymal stem cells and other healing cells from your bone marrow to treat orthopedic conditions. And this all started in 2005. The Centeno Schultz Clinic in Broomfield, Colorado, was the first clinic to begin treating orthopedic conditions using highly precise stem cell injections. So what is interventional orthobiologics? Well, interventional refers to the fact that we use high-tech, high-resolution imaging guidance to guide all injections and procedures. And on the left, the picture on the left, that shows an ultrasound machine and an ultrasound suite, which we use for the vast majority of our procedures. And on the right, that is an image of a fluoroscopy suite. So fluoroscopy is like real-time X-ray. You can take pictures, you can take brief videos. It's very low dose radiation, and we use that for procedures that we may have to get inside a joint to see where the needle is, such as treating ACL tears in the knee, or if we're doing injections into the bone itself, called intraosseous bone augmentation. Those situations we need X-ray guidance because ultrasound waves bounce off of bone. I can see lots of structures, a lot of things I can see better on ultrasound than I can with MRI. But if it's deep inside a joint, the sound waves bounce off of bone, and you need fluoroscopy to guide those injections. Now, orthobiologics refers to ortho meaning joint and biologics meaning tissues or live cells. So we don't do your typical steroid injections. We don't do surgical procedures to place artificial joints in your body. We use your own cells to treat orthopedic conditions, and thus the term orthobiologics. So it's really the core tenets of it's this new specialty. It's a new specialty that we have really come into fruition probably in the last 10 years. And And with medical orthobiologics, we use injectates to facilitate healing of bone or tendon, ligament, muscle, cartilage, as opposed to just doing injections like steroid injections or cortisone injections that take away pain but actually are damaging to your joints. And we use high precision placement of those injections using image guidance, like I discussed. So when a lot of people will say, "Oh yeah, you can have a PRP injection at our clinic." PRP means platelet-rich plasma, or yeah, we do injections at our clinic. Lots of orthopedic, sports medicine clinics, family medicine clinics will do simple injections, and that represents about 95% of the U.S. physicians, meaning you're just putting a simple injection into a joint, not using guidance, not addressing the support structures around the joint, but just putting a shot in the joint. And now about 4% of US physicians will use guidance, and mainly ultrasound guidance or fluoroscopy guidance, which most commonly is seen in pain clinics doing spine injections. But only a small percentage are considered interventional orthobiologic physicians. And there's a big difference. So the patients the clinics that I mentioned where they may have a pain clinic where a spine doctor is doing a spinal injection. In general, they'll inject one structure. For example, they might do an epidural injection on one side of the neck to treat one of the nerves coming out of the neck, or they might do a joint injection on one of the joints. When we're talking about the peripheral joints, in this picture here, we have a picture of the hip. The simple injection, they just try to put it in the joint, and hopefully with guidance. But unfortunately, a lot of physicians, 95%, don't use any type of guidance. But in our clinic, if I'm treating your joint, well, first off, when you come in for an evaluation, I assess not only your hip, but your knee, your ankle, your back, the whole kinetic chain. And when I do the hip evaluation, which I use ultrasound in conjunction to my physical exam, we look at not just the joint, we look at the connective tissue around it, the ligaments that attach to the joint, the gluteal tendons that attach on the side of the hip, the labrum, the ligaments, and these are all areas that often need treating. So with the Regenexx sort of treatment processes, we don't just treat in the joint, we treat the whole functional unit. So in the knee, you've got multiple things that could be pain generators, not just the arthritis. We have our quadriceps tendon, our patella tendon, the collateral ligaments around the knee. And so when I do an evaluation, I look to see, are there areas of instability where maybe the ligament isn't torn? It might not show up on an MRI radiologist report as a tear, but when I do your exam, I watch with ultrasound, and I can dynamically stress a joint and see with the ultrasound where there's laxity. So in our treatment plan, yes, you may have an arthritic knee that we're treating the degenerating cartilage, but I may be putting numerous injections in the ligament that go along the side. You may have a lax ACL ligament deep inside. The medial meniscus or the lateral meniscus is most likely degenerating, and we inject that. And so it's a much more robust, much more thorough evaluation than you might get at other clinics, and a much more thorough, robust treatment plan. Similarly, in the shoulder, it's the same story. We have numerous ligaments and tendons that we can treat. It takes a lot of training to know how to do some of these deeper supporting ligaments that are mentioned here, like this label of MGHL, or there's a SGHL. These are some of the deeper ligaments that keep the joint stable. So again, if you treat a joint that's arthritic and the joint is unstable, that instability results in further breakdown of the joint and the cartilage. And so we always address the stability. So in the Regenexx network, we're all very highly trained physicians before even coming into the Regenexx network. And then there's significant amount of additional training that Regenexx doctors undertake. And I mentioned all our injections are use guidance such as fluoroscopy or ultrasound. Our cells, or I should say your cells, your platelets or your bone marrow cells are processed in a clean room facility and not just a simple low-tech bedside a machine that may produce a low concentration of platelets. And this is backed by a multi-million-dollar research lab and facility in Colorado, where they also have a fellowship training program in Colorado to train physicians. And it's a large network, a big benefit of being in the Regenexx network is we have the world's largest orthopedic outcomes registry. So what does that mean? Well, I've worked in a couple of large orthopedic groups over the years before doing purely regenerative medicine treatments, and none of those surgeons ever tracked how well did the surgery work. They never sent surveys to the patients years down the road to see what's their function level, what's their pain level. They basically say, yeah, this works, the knee replacement, yeah, I get good results. Well, Regenexx, ever since 2005, they had the foresight to say, let's track how well do these procedures work and how long do they work and in what patients do they work and what was actually used. And so for every procedure that's done, we ask our patients to participate in our outcomes registry. And that means before we do a procedure, we ask you to fill out a symptom and a function survey that asks things like, what can you do? How is this limiting your life? What can't you do? What's your pain level? And then after a procedure, you get similar surveys sent to you at 1 month, 3 months, 6 months, 12 months, 18 months. When you get to 2 years, they come once a year that you generally sent to you via email. And so we can track and see how well different procedures work for different degrees of damage. So we use that to help me guide my guidance for the patient. So when a patient comes in, we go through an evaluation and I look at what are your treatment options. I'm going to give you a candidacy rating. I'm going to say, for someone your age with this type of problem, you're a good candidate for procedure A or procedure B. Or maybe you're only a fair candidate, or maybe you're a poor candidate. We have some conditions, for example, hip arthritis. If the hip arthritis is severe, if you have end-stage hip arthritis, our data that we've been tracking for 20 years now would say, go get your hip replaced. Our data, we don't think we can give you years of relief, whereas knee arthritis, you could have severe knee arthritis, and our data would say, we expect you to get 7 to 10 years of relief, some longer, some shorter. Obviously, with any statistics, there's a distribution curve. But we'll say, okay, you're a good candidate for this procedure. And I use that outcomes database, the registry, as the baseline for my candidacy rating. Other things that come into play when we're determining, are you a candidate for one of our procedures? We look at your lifestyle. We look at, are you active? Active bodies heal better. Do you have numerous medical conditions? People can have heart disease or diabetes and still be a candidate for a procedure. It's just patients are on many medications who have multiple, let's say, metabolic disorders. Their bodies aren't as strong of a healing environment. And so that makes you a little lower candidate for a procedure. And so we work with our patients. We'll say, well, we want to maximize your chances for a positive outcome. What can we do? So we look at strength training. There's good research showing that muscle strength training will stimulate stem cell activity in your body. We look at your diet. How can we make changes to your diet to decrease inflammation in your body? Um, and those types of changes are helpful not only for your joints, but for your heart and for your brain and for your kidneys and your liver and your intestinal biome. So we look at lots of different ways how we can increase the overall health of your body to give you the best chance for success, and get the biggest return on your investment in your body. And that's what I look at this as, is it's an investment in yourself. It's a way of these treatments are a way of maximizing your chances for healing and to help you avoid going through in a surgical procedure and to help you keep all of your body parts. So I mentioned we have this large database. Currently, well, as of a couple days ago, we have over 22,000 knee cases that we're tracking in the database. Lumbar spine is number 2, over 17,000, and then you can see shoulder, hip, cervical spine, foot and ankle, hand and wrist, and elbow. And that's over the whole Regenexx network. If we looked at my own data, knee would probably be number 1, probably followed by shoulder, hip, and then I think I see more elbows than foot and ankle. But those are the numbers. So they're large numbers. So here are some examples of what we're talking about when we're talking about interventional orthopedics. So on the left is a fluoroscopy machine, a real-time X-ray machine. On the right, there's 2 pictures. The top one is what the fluoroscopic image is like. The bottom one is the corresponding MRI. So on the top, on the right here, the dark areas are bone. This little dark line is contrast dye that was injected. This is a little needle going into the joint space. This is verifying that the needle's in the right spot. This darker line here, that is a bone trocar. That is a when we're doing an intraosseous, meaning into the bone augmentation procedure. So that is the most advanced non-surgical techniques for treating arthritis, is actually putting healing cells such as mesenchymal stem cells, monocytes, macrophages, different cells from your bone marrow into the bone, into this area. This white area is an area of bone that is inflamed and swollen and degrading, and the cartilage gets its nutrition through the bone. And so there has been a large amount of research done with probably the most famous studies done by Dr. Philippe Hernago in Paris, showing how you can halt the progression of arthritis and treat arthritis by treating inside the bone. And that is something that we do frequently in our procedure room. You don't have to be under anesthesia for that. And it's something that really sets Regenexx apart from other clinics, because that is an advanced treatment, and we've got great data to show how well it works. So another interventional orthobiologics procedure here is treating ACL tear. This shows the position of the patient. These are fluoroscopy images. The dark globules, that's contrast dye that's injected to show that we're in the right spot. And those are the bands of the ACL, the anterior cruciate ligament in the knee. And then so we inject contrast first to verify where we are, and then we put our injectate, be it super concentrated platelets or bone marrow extract, into that. This shows a shoulder procedure. That's a fluoroscopy guided injecting a shoulder labrum. That's what this sort of triangular view is, of contrast going into the labrum. Labrum is the lip of cartilage along the socket that can often have tears. And then we can, this picture here shows an ultrasound procedure where this fluid is what we've injected around the nerve in the wrist called the median nerve. That is the nerve that gets compressed and damaged in carpal tunnel syndrome. So we have a treatment for nerves that works well for carpal tunnel, where we draw your blood, extract the platelets from the blood. Platelets in your own plasma is called platelet-rich plasma. We then can isolate the growth factors from the platelets themselves. We can break the cell walls of the platelets, release their growth factors, and inject those around the nerve. That's called platelet lysate. And so that's an example of a wrist procedure for carpal tunnel syndrome. So why do we think interventional orthopedics will replace elective orthopedic surgery? Well, for one, we're already doing that. We are already replacing, or at least postponing, a large number of hip and knee surgeries in our practice. And as a matter of fact, I mentioned Regenexx has this enormous database of outcomes. We have been able to approach companies around the country that provide insurance, self-funded insurance plans to their employees, and we've been able to show our data to them and say, look at our data. We have great research not only at Regenexx but around the world showing that these types of procedures work well, and our outcomes data show just how well they work. And so there are currently over 2,000 companies around the country that will pay for Regenexx treatments, regenerative medicine treatments, if they're done at a Regenexx clinic for their patients, sorry, for their employees. And that is called our corporate program. So just within the corporate program, our whole goal is to help them avoid a surgery at a lower cost with a quicker recovery time and quicker return to work and return to play time frame. So why? Because it's less invasive. I just mentioned we recover quicker, and you get to keep your body parts. So you preserve your biomechanics. And not only do you preserve them, we work on how can we maximize your biomechanics. I mentioned how I'll do numerous injections around a joint to strengthen lax ligaments and lax connective tissue to make the joint more stable. And we also have you work with a physical therapist to work on rehabbing the muscles that may have gotten weak over time and help stabilize the area. And not only that particular joint, but the therapists we work with, we give them instruction, and many of them have more advanced physical therapy training than your run-of-the-mill physical therapist. But we work on really having them look at the whole kinetic chain. So if someone is going for therapy for their knee, we tell the therapist we want you to address these hip or these lumbar spine mechanical issues as well. So what types of injections do we do? When we're talking about orthobiologics, what does that refer to? Well, the most common type of injectate is called PRP, platelet-rich plasma. And that is where we use your body's own platelets to help heal your body. Platelets are, most people know that, okay, platelets are those are the cells in my blood that help stop bleeding and form a clot and a scab and a scar. And that's one of the things that they do. Platelets do, when platelets promote healing, they don't turn into new cells. They don't turn into new tissue. The way platelets work is when they come into contact with connective tissue, such as collagen in your skin or tendons or ligaments, they release numerous growth factors that different cell types take up and start growing. There are growth factors that promote bone healing, that promote new cell growth called fibroblast growth. The fibroblasts are cells that are in tendons and ligaments. There's growth factors that stimulate cartilage cells to grow. Growth factors to promote new blood flow, new blood vessels to grow into the tissue, because you need blood supply for tissues to heal. And what's really important is the platelets release some growth factors that one of them will stimulate your own stem cells in the area to become more active and to actually migrate towards the platelets in your tissue. The other one is there's a growth factor called transforming growth factor, and that causes stem cells in the area to transform to their final cell type. So platelets are potent cells that help do this. And there are lots of clinics that do platelet-rich plasma injections. What sets us apart is we can make the dosage or the potency or the concentration of that PRP many times higher using our state-of-the-art techniques in lab than other clinics can do. The platelet-rich plasma works well for mild arthritis, for tendon and ligament tears, sometimes up to moderate arthritis. When we get into more advanced arthritis, that's when we start talking about using more potent cells from your bone marrow or even from adipose tissue. So I mentioned there's numerous growth factors that are released by platelets. Here's some of the main growth factors. I'm not going to go through all of these, but they're ones that I talked about: the transforming growth factor, the PDGF, so the growth factor. So there's numerous growth factors, and that's how the platelets work. A big part of it is stimulating your own stem cell activity. So we look at other things as to how to stimulate your stem cell activity, and when you're in the evaluation with me, I go over numerous things such as strength training that can stimulate stem cell activity, intermittent fasting, changes in your diet. So our goal is to really maximize your healing environment. Another product that we use is platelet lysate. That's the thing I mentioned that I would inject around a nerve. This works really well around nerves. It has more anti-inflammatory effects and helps nerves recover and help establish the microvascular blood supply to nerves. So when nerves are being impinged, or when nerves are being entrapped in, like for instance, in your wrist, or if a bulging disc in your neck is pushing on a nerve, the nerve itself has very, very small blood vessels, and it needs them to provide nutrition to the nerve cells in the nerve. And so the growth factors from platelet-rich plasma, or in this case, what it's called platelet lysate, which is another step that we do to the platelet-rich plasma to release the growth factors. These growth factors will stimulate not only nerve healing, but stimulate improving the blood supply to the nerves. So a lot of people will ask, well, why, if platelets are in our blood, why aren't they getting there anyway? Why do we have to take them from our blood and and then inject them? And the reason is our skin, areas like our skin, has a great blood supply, and the platelets get there right away. They stop you from bleeding, and you start forming a scab and new skin. But tendons and ligaments, cartilage don't have a good blood supply. So we extract the platelets from your blood and then put them where you need them. So to kind of think about how this happens, we draw blood from your arm, many vials of blood, depending on how many areas we need to treat, and how many platelets we need to pack into a small volume of plasma. But anyway, we draw many vials of blood, then we separate the layers of blood out to separate the red cells from the white cells by placing these vials in a centrifuge. So then when we've separated out the red cells and the white cells, what's left is the plasma, which is a clear yellow layer of your blood. And that's where the platelets live. So imagine if we've got many tubes of blood, and we take out the plasma layer from those tubes of blood and combine all those plasma layers into a large collection. Well, now we've got a large collection of plasma with platelets flowing all throughout the plasma. Now we extract all of those platelets and put them back in a very small volume of plasma. So we've really increased the dose or the concentration. And with our custom lab, for every patient, I'll tell our lab processor I want so many mLs of 20 times concentrated platelets, or I want so many mLs of 10 times concentrated platelets. So everyone's treatment plan is customized, whereas other clinics who'd use a simple bedside device, everyone gets the same concentrations. So they don't have the ability to customize it, and that concentration that they provide is significantly lower than what we can do in Regenexx clinics. So that people want, I mentioned for more advanced conditions, we'll use stem cells, and the real term for that is MSCs, mesenchymal stem cells. And so we isolate these, and there are many other healing cells in the bone marrow that I mentioned: monocytes, macrophages. The stem cells are actually a small portion of the healing cells that we extract from a patient's bone marrow. So we aspirate that from the back of the pelvis, and then we can similarly, but in a much more detailed technique, we isolate two small layers of the healing cells from the bone marrow, and that's called BMAC, bone marrow aspirate concentrate. And so these also they stimulate stem the way these MSCs work is they really stimulate healing in the area. They're like general contractors that are organizing all the other cells in the area. They have pain relieving properties. Um, and at the end of the day, they can turn it into the cells. So people, there's often a lot of anxiety about the process of having a bone marrow aspiration because people hear horror stories about cancer patients who've had painful bone marrow biopsies, or that's usually the main, or it's some regenerative medicine clinics um, that have done that do bone marrow draws. Sometimes it can be a lot more painful. But so on the left here, this shows the bone marrow aspiration devices. In the middle here, that's a picture of one in the palm of my hand. And that device actually, it's got, if you look over on the left, the bigger part here is what actually we go into the bone with, and this part here is inserts in the middle of this. This has a sharp tip, it inserts in the middle, and it's removable. So the bone, and over on the right here, this shows actual bone marrow being aspirated from a patient. And so it looks like blood, a little thicker than blood. And that's called the BMA, the bone marrow aspirate. So it's a sterile technique. You see the pictures there in surgical gowns, and the patient is prepped with, I prep the patient, scrub them with surgical soap, and have surgical gowns and surgical drapes. We use IV conscious sedation, meaning we start an IV and give you a sedative. It doesn't knock you out. You're just kind of a little sleepy, and if you're having any pain, we can push pain medicines through the IV, short-acting pain medicines, and patients tolerate this extremely well. Every time I'm drawing bone marrow out of a patient, I'll ask them at least once as I'm aspirating it into the syringe. I'll say, "Tell me what you feel." And 9 times out of 10, they say, I can't feel anything. And it's not because there's oncored from the IV sedation, because we use light sedation, and it's because, there's several reasons. Part of it is the technique that we use, and part of it is that I anesthetize down to the surface of the bone before we enter the bone, and the technique that we use in Regenexx clinics is results in less pain. So on the left here, this shows the position that a patient is in. We draw the bone marrow from the back of the iliac crest, your hip crest. In the middle here, it shows a zoomed in picture. The bone marrow is kind of like a honeycomb appearance, and we have healing cells and stem cells on the walls in here, as well as blood in there. And then the thick wall, I mean the dense wall of the bone, called the cortical bone, has no there's really no pain sensor cells in the bone, or nerve cells. We do have sensory cells on the outside layer of the bone, and that's that's the area that I anesthetize with numbing medicine first. What patients will feel is a pressure change. So if we inject into the bone, or if we aspirate bone marrow from the bone, you can feel the pressure change. And in other clinics that do this procedure, or with bone marrow biopsies, they'll go into the bone marrow, enter fairly deeply, and then draw out a lot of bone marrow all at once. And that large pressure change is what hurts. At Regenexx, our research labs in Colorado, they've looked at what is the best way to get the highest number of cells from your bone marrow, highest number of live cells. And it's not going all the way down into the bone and drawing it all from one spot. What we do is we come in from the side and draw a little bit just under the surface of the bone. Then I advance that trocar half a centimeter deeper, draw a little bit more, and then advance it and draw a little bit more. And I do that at numerous locations, 4 or 5 locations along the iliac crest. And because we do that to get higher cell counts, but because only a small amount of bone marrow, like 5 cc's of bone marrow, is being aspirated at any given time, there's not a huge pressure change. And so patients tolerate that very well. So we do this, there's 2 layers of the blood that I said, of the bone marrow that we extract the buffy coat and lipid layer. They're done manually in our lab. And there are numerous cell lines in the bone marrow that promote healing, not just mesenchymal stem cells. So I brought this up before. Why don't the cells go there automatically? Because it's because most of those areas don't have a great blood supply. So if you think of it, we're taking lots of platelets or bone marrow aspirate, concentrating it into a small volume and guiding that with precision to inject it directly to the areas that need repair. So there are numerous areas that we treat daily, day in and day out. We treat severe knee arthritis, moderate knee arthritis, mild knee arthritis, patients who have been told they need a total knee replacement. In those cases, we do the bone marrow procedure, and those patients are considered good candidates. They see rotator cuff tears, ACL tears day in and day out. So we're able to treat patients with severe knee arthritis and help them avoid knee replacement, that has been so. I mentioned how we can inject into the bone. We can also inject bone marrow concentrate right on the surface of the cartilage where the bone has been damaged. There's a large study of 200 patients that was done in over the course of 15 years. Patients were followed for 15 years. A surgeon, Felipe Hernago, who's like the pioneer in doing bone injections into the bone to promote healing in an arthritic joint. Dr. Hernago is an orthopedic surgeon in Paris. He's probably in his 70s now. I just talked to him at the Interventional Orthobiologics Foundation annual conference and meeting this last week in Scottsdale. He was there, and he currently is now on the medical staff for Regenexx. But he first started doing, so he does knee replacement and hip replacement surgeries. He does 200 a year. He's now, as he's getting later in his career, he doesn't do as many surgeries. But for most of his career, he'd do about 200 joint replacements a year. He did a study on patients who had severe knee arthritis in both knees. He had 200 patients, so 400 knees. Every patient in the study, they would get one of their knees would get a total knee replacement, and the other he would do a bone marrow extract injection into the bone called bone augmentation. And he followed these patients for 15 years. There were a small number of maybe 20% of the knee replacement patients who in the first few years rated their outcomes a little higher than the bone marrow patients. But after the 15 years, I want to say it was 86% of the patients reported that they were happier with the bone marrow procedure as opposed to the total knee replacement procedure. Now that's 15 years down the road, and that was just one procedure. Because sometimes we'll do a procedure, and if 5 years down the road, if a patient is starting to have pain again, we can give them a booster type injection. But bottom line is, these are patients that are comparing a total knee in one knee and the bone marrow procedure in the other, and they had better outcomes. He also looked at the data to see how many of those total knee replacement surgeries had to have a second total knee, had to have that joint taken out and put another one back in. So he had 20 of the patients had to have a second, what's called a revision, and only 4 of the stem cell bone marrow patients knees ended up having to have a total knee replacement. So we can treat severe arthritis in the knees. Hips don't do as well, but the knees we definitely do well. So I mentioned, that number. This slide is a little old. Actually, that date is way old, but we have 22,000 knees that we're tracking. But the overall the function in slide 2, that data is data I just pulled the other day. Same thing with number 3 over here. These patients saw overall knee improvement of 39% by 1 month, 51% by 3 months, and 62% by 6 years. And their functional ratings, so the initial rating was how well is your knee working. That was, they said, oh, I've got about 56. On average, they came out to 56% functionality. And that increased by these numbers up to 76% beyond. And then these patients had, in our registry, we see a 45% pain decrease by 1 month, and that continues to improve over the ensuing months. So I mentioned bone augmentation. That's where we'll actually, this MRI shows a knee where the bone is breaking down inside. That's what this white is. This is called a bone marrow lesion, and we can treat that. We can get that swelling in the bone and that breakdown inside the bone to heal, and by injecting into the bone. And we use fluoroscopy to guide that. Patients can have a bone marrow lesion like this, and maybe they have just mild knee arthritis. Well, a bone marrow lesion like that is a precursor to rapidly progressing knee arthritis. So we can nip it in the bud. So these are just some pictures of showing so bone augmentation. We use a similar tool that we use to draw bone marrow out of the back of your pelvis, but it's shorter and it's a little skinnier. It's an 15 or an 18 gauge kind of needle. This is the type of thing that we use. So we're also, we can help people with ACL tears to get the ACL tear to heal back, provided they're not completely ruptured and separated by more than a centimeter. So we can treat partial tears, full thickness tears that aren't retracted, but for full thickness tears with retraction, those need to go to surgery. So similarly, we treat moderate to severe shoulder arthritis, help patients avoid shoulder replacement, or help avoid rotator cuff surgery, and we can treat tears of the labrum. And like I mentioned before, I treat fingers, hands, wrists, elbows, ankles, feet. So, but those big joints are the main ones that most people have as their largest concern. So I just want to address some of the stem cell hype that's out there. If you go on your search engine of choice and type in stem cells, you'll see all kinds of things pop up: books, blogs, clinics, chiropractic clinics doing embryonic tissue injections or cord tissue injections, or I've seen Morton's jelly injections, placenta injections. There's a lot of hype, and there's a lot of misinformation. There's people say, oh, I went to this clinic and they did IV stem cells and it went through my whole body and it treated my brain. And there's a lot of misinformation out there. But fortunately, for over the last, oh boy, maybe 10, 15 years, there have been institutes like the Interventional Orthobiologics Foundation, a group called TOBI, the Orthobiologics Institute. Different medical societies have been saying, hey, we need to standardize, we need to show what's effective and what isn't, we need to have good research, and there's profound amount of research showing that these procedures work, but there are things that are sham procedures. And so when we're talking about new technologies, there's kind of 3 phases of adopting these technologies. And initially is the thought that, oh boy, this is great. It works for everyone. It works like magic. And as you do more and you learn more, you realize, well, it's great, but it helps almost everybody, but maybe not everybody. And then as you have a more mature knowledge of the field, you say, let's figure out who is a good candidate. And that is something that's definitely is what we do with every patient. We tell you what your candidacy rating is. And it's something that I would wish that every medical profession would do. If you're having heart surgery, I want them to tell patients, you're not a very good candidate, but you don't have much, many other options. I at least tell what your candidacy is, or you're a great candidate. Our data shows patients have great outcomes. But unfortunately, there just isn't a great amount of follow-up on a lot of procedures. But once again, At Regenexx, we follow all of our procedures to track how well they do. So, like I mentioned, the biggest abuse that we see is the amniotic or placental or cord stem cell injections. These products have been evaluated extensively, not only at Regenexx, but at large institutions. And these amniotic tissue products are dead tissue. There's no live viable cells. And if you think about it, it has to be. It has to be sterile. It has to be sterilized in order for anyone to sell it on and sell vials to the local chiropractor clinic to inject. Otherwise, you'd have immune reactions. You would have risk for infection from getting someone else's cells. But they're actually regulated by the FDA as dead tissue. Now some of the reps for these companies will say, "Oh, but there's growth factors in there." Yeah, maybe there aren't live cells, but there are growth factors in there. Like I mentioned, platelets release growth factors. And that's been evaluated and looked to see, yep, what are the levels of biologic growth factors? And as it turns out, there are growth factors in those products, but there are fewer growth factors than one would find if you just drew if we just drew your blood and just injected whole blood into the area. So if you see anyone saying, "Oh, I can get stem cell injections from cord tissue or placenta tissue," save your money and walk away. All right, so at this time, I like to bring up a lot of time for you to ask any questions, or I'm also going to show you our contact information. You can look. Our website at regenexxdemoines.com has lots of information and links to our outcomes data that I mentioned. We have, if you go on the website, you can get to areas that are treated, and you can see what the latest outcomes data shows. This is our address in Des Moines. We're off of 63rd Street, kind of down by Walnut Woods. Just on the border of West Des Moines and Des Moines. And this is a number you could call to get to the front desk. But really, for the best way to if you want to be seen for an evaluation, would be to go to this website, our Regenexx website. And on that site, there is a form where you enter your contact information, and that goes directly to our patient education and scheduling team. So they would reach out to you, even if it's after hours, and they can go through talking to you about what areas you might want to be treated and when can we get you in. Well, if there are no other questions, I'm going to end our webinar. I thank you for coming, and just want to let you know we will be I'll be doing another webinar probably in the next 3 or 4 weeks. That might be more focused on a particular body part. I see a question just came up in the chat and says, is there an age limit? Well, really, there is not an age limit. Many people have asked, well, don't we lose our stem cells? Or aren't our stem cells less effective as we get older? That's been studied in detail, and yeah, the younger we are, the higher number of stem cells we have in our body, but we account for that. So based on the age of the patient, it's been well studied, not only on stem cells in your bone marrow, but it's been studied to see what concentration of platelets do you need to effectively treat, let's say, an arthritic knee or a tendon issue. And that's one thing that we do at Regenexx clinics, that other clinics just have not caught up to at all, is there's great data that tells us as we get older, we need to use a higher dose or higher concentration of platelet-rich plasma, which means we need to draw more blood for that procedure. And so we adjust the dose based on the patients. We also know how many live cells we need to have an effective treatment from the bone marrow. And one thing that we do at Regenexx clinics that other clinics aren't doing is we test the bone marrow concentrate that we get from that particular patient and look at what's their level of live cells and how viable are they. And I routinely try, so even if patients have a lower concentration of stem cells or other healing cells in their bone marrow, we take that into account, and we really get uh, we have patients who are in their 80s. I've had a couple patients in their 90s who have knee arthritis, and the surgeons have told them you're too old to do a knee replacement, or you've got heart disease. You don't want you to go under general anesthesia, um, and they've done well. So I really don't see an age limit. So Kim has her hand up. Do you have any other things you want to bring up uh, with the rest of the participants? And you're currently muted, but if you still have a question, or maybe I answered your question about the age limit, but if you don't have if I've answered your question, great. Otherwise, if you unmute your mic, you can talk to all of us. And I'm going to guess. There you are. So do you have a question, Ken? I don't hear anything. Or if you still have a question, you can put it in the webinar chat and I can answer it. But if not, this webinar will be, the recording will be available. And if you can share it with friends if you want. And like I said, we'll be doing another webinar in about 3 or 4 months. So the question is, what about shoulder back pain that's across the back? So shoulder and back pain that goes across the back, I see lots of shoulder pain. We can have patients with actual shoulder joint or shoulder muscle issues, that they can also be getting pain behind their shoulder blade because of altered mechanics, because they're compensating for, let's say, arthritis in their shoulder. I've also seen patients with pain in the back of their shoulders where the pain is coming from their neck, from their either arthritis in the joints in their cervical spine or impinged nerves. And so that's one reason why whenever I do whenever I have a patient with shoulder pain or elbow pain, we do a neck evaluation as well. And there are patients who have both a cervical spine issue and a shoulder issue, or there are patients who have only a shoulder issue that can have pain across the back of the shoulder. And there can be patients who have a neck issue and their shoulder exam is all completely normal. So if that's the case, like I mentioned, we currently aren't doing any spine injections in our clinic. Hopefully soon we will have a physician that can do them. And if not, what I generally do is set you up with another Regenexx physician in the region who could do the spine injections if they're needed. So hopefully that answers your question, but they are interrelated, just like hip conditions and low back pain can often be interrelated. It can be very hard for physicians to ferret out is this person having a back issue or a hip issue. And another question is this helpful to knees that were replaced 15 or 25 years ago? So there's nothing we can do. So the fact that the knee's been replaced means there's no arthritis in that knee anymore. Meaning arthritis is wear and tear, degeneration of the cartilage. That doesn't mean that the knee doesn't hurt. So there can be structures around the knee. You can have ligaments around the knee that are lax, the muscles or the quadriceps tendon or the patella tendon could be inflamed or wearing down or degenerating around an artificial joint that we treat. If it's an issue where the artificial joint just is not aligned properly or is wearing out, that's a different story. So if when patients are having, let's say you've had a knee replacement 15 or 25 years ago, surgeons will tell you, well, we expect this to last maybe 15 or 20 years. And so that's one reason why orthopedic surgeons want to try to delay knee replacement as late as possible within reason, ideally into when patients are into their 60s or early 70s, so that when they get a total knee replacement, it lasts them the rest of their life, ideally. But sometimes they start loosening and wear out and have to have a revision where they take out the artificial knee and put in a new one. So if someone that has an artificial joint and they're having pain, I'd say the first thing I would recommend is that they see their surgeon just to make sure that the hardware is not loosening. And oftentimes, and they'll do tests to verify that. And then oftentimes they'll say, nope, your artificial joint is looking great from our standpoint. There's nothing more that we can do. And when that's the case, and when that happens, oftentimes it's an issue with all of the ancillary support structures. And for those conditions, that's where we use platelet-rich plasma to address those external supporting structures. And so yeah, I have just this year I've seen a handful of patients with total knee replacements that have had problems not with the artificial joint itself, but with the connective tissue around the joint. So hopefully that answers your question. All right. Well, again, I'd like to thank everyone for coming. I hope you found this helpful. I hope this gives you hope because we can definitely help you avoid elective surgeries and treat your pain and treat your degeneration and get you back into doing all the things you like to do and keep you moving and keep you active. That's the goal. So have a great night, and maybe I'll see you at our next webinar, or even better, maybe I'll see you in the clinic in Des Moines. So take care and have a great night.